This is the parasternal, apical, subcostal aneurysm. So parasternal view we started, go to the apical, look for 4 chamber, 2 chamber, 5 chamber. These two generally I used to finish because we have to do 20 echoes per day approx. So 15 minutes our approximately time, it took 2.5 hours for daily for in echo. But ideally we have to give 30 minutes if you want to in the theoretically details of the various parameters and all that thing. Minimum 30 minutes to 35 minutes because of this. But what we are practicing clinical echocardiography, whether we want to outcomes of patients related to data, common data and that. So two views are enough for the most of the information for the parasternal view and apical views. But if there is ASD or any pathology related to blood, we have to go for subcostal view, and particularly for the other related to aorta like information, we have to go for the suprasternal. Now there are some pictures. Day-to-day practice. Every day we used to see. This is the picture whether we see that the wall motion hypokinesia. Okay, this is still pictures. But when you see the moving picture, the respect of the hypokinesia or the so wall hypokinesia is a basic thing. We have divided echo-wise heart into the 16 to 17 zones, and that zones according to whether it is a normal wall motion, abnormal wall motion. If normal, then again hypokinesia, or if no motion, less motion, hypokinesia, no motion, akinesia, opposite motion, dyskinesia, and if there is a abnormal dilatation, aneurysm. So these are the 4 stages of the wall motion hypokinesia, and we have to see whether interior wall, if anterior, upper part, middle part, lower part, if inferior, upper part, lower part, if septum, upper part, middle part, lower part. So this like we have to in various zones and look for the so wall motions abnormality is a very important parameters for the information. Look for this. We can see this is the LV, and we see what is that. Is it a normal LV? No, it is abnormal. It is a hugely dilated. It is a dilated cardiomyopathy, and see regurgitation of that. So dilated cardiomyopathy is one of the important part we can see immediately, and see the how much is the normal. Your diameter is normal is 55. Here is the 64 centimeter, 6.4 centimeter, and your normal is the 0.5. So thinning of the septum, dilatation of the chamber. This is the DCM. So similarly, opposite of the DCM, here it is the your hugely hypertrophy of the septum. So this is the, and there is the obstruction of the alveolar obstruction. So opposite of DCM, this cardiomyopathy is the hypertrophic cardiomyopathy. It is the HCM. So what is the mid cavity gradient? What is the alveolar gradient? This is a very, and this will lead to the formation of the motion of the AML will be restricted, that is known as your the SAM, and S is the asymmetrical septal hypertrophy. So this is the basically the HCM. Similarly, this is the PDA. You see aortic root. Then here the descending aorta, and then the jet. So this is the very classical PDA picture of the echocardiogram. This is the basically tricuspid. You see, it is the one of the congenital heart disease, and if you look carefully, then the disease will be very commonly can be said from that. Postgraduate, can you see? Can you comment on that? What is that? You look for the valves. Here is the mitral valves, and this is the place for the tricuspid valves. And tricuspid valves is looking here, and mitral valve is here. Ideally, this should be in the same plane. So, what is the diagnosis? It is the diagnosis of the Epstein anomaly. Yes, Epstein is the when there is a the displacement of the tricuspid valve toward the apex. So it is this is the mitral valves, and here ideally this should be the place for the tricuspid valve, and it is 3 centimeter towards the apex. This is the tricuspid. So this is the classical Epstein anomalies, and we have reported 4 cases from our hospital. Here, even डॉक्टर साहब आपका जो एक पेशेंट फ्रॉम राउरकेला, that lady was Epstein anomalies, infertility case, and we have 3-4 boys we have diagnosed here in Epstein. So Epstein is not a rare disease. We have last 10 years में 4 to 5 series of Epsteins we have got it, and report are also saying Epsteins can live up to even 70 years. They have reported. So 25-30 Epstein we are getting. So this is the how you can see the echo. Very easily we can see that it is the Epstein anomaly and look and follow. Similarly here we can see the whole this is the LA, LV, RA, RV, and see the LA is full of what is this? Mass. And we have 5-6 cases, more than that. In our hospital we have diagnosed, operated, re-emerges recurrence of myxoma. So one RD Misra RPF from Adra, basically patients came with the patient came with a stroke. And when PCA stroke was there, CT was done, and when as a routine for knowing the no murmur was there, as a routine echocardiography we have got, there is a big myxoma was there in the right atrium, and finally operated. He become all right. Again after 2 years, every year we used to call him from Adra, and we came again after first visit it was all right. Second visit there was recurrence of myxoma. Again I sent him Dr. Reddy, was Jagannath Reddy. I talked with him, sir, there is a recurrence very common, rarely 5% cases only recurs. Then he told, okay, I'll do this time with the more deep dissection of the actual symptom. And finally dissected. Third, fourth, again we have checked up, and now it is all right. And presently last so there is a myxoma, 5-6 cases we are having here. This is the subcostal view, and see every month we used to see this type of. Yesterday just one person again from Adra, one lady with breathing problem, low voltage ECG, BP was not, and huge cardiomegaly, and immediately sent to in civic clinic. Yesterday we did the immediately echo, and the echo was similarly the huge. You see, this is the heart, and what is that? This black and white, this area is basically fluid, pericardial effusion. So pericardial effusion, that lady we will pericardiosynthesis will do. Similarly, pericardial effusion is a very important finding. We can see in 10 seconds hardly. This is the heart. Heart will start the moving inside the, just like a water, all the part, and heart will float. And most danger sign for this is known as big strides. And when there is a pericardial tamponade, there will low BP, pulse will down, and here there will be the sign of your compression, RV compression. This is RV is compressing, then there will be the no filling of the RV, and that will known as the cardiac tamponade, and most dangerous situation of the this. So this is the pericardial effusion. And ultimately the treatment of choice is the pericardiocentesis. One important, we have almost around 50 cases in follow-up cases around in our hospital. Here this is important, is the basically mitral, any valve, prosthetic valves. And prosthetic valves, what is this? You see one the mass like a structure with the high sclerosis here, and this is the basically prosthetic valves. But how to do prosthetic valves echo is a basically we have to go for the detailed models of the prosthetic valves. How many cusps they are having? What is the model of that? Ball and socket. There are Medtronic's valves. There are St. Jude's valves. There are variety of the type of the Sevigny Centier valves. So from old days valves to new valves, we have a very good idea of the model of valves. Otherwise, we cannot comment on the valves. Then the prosthetic valves, we have to see what is the motion. We have to see is it a degenerative or not. One is known as Townsend's Panus. We have to report. That later after 15 years, the valve started degenerating. or most important dangerous is thrombosis also, because prosthetic valve patient died suddenly, or 1 day, 12 or 15, it is a very catastrophic outcomes. So whenever there is a valves, if it is going on all right, if there is any problem, it is a very dangerous sign. And gradually from the thrombosis to your valve failure, the extent of the valve failure, we have to assess through the echocardiography, and generally we used to practice 1 yearly echo in every patient. We are having follow-up around earlier, lot of patients have died, or we have around 50 nowadays at present, the valve patients. So we used to be very careful for two things. One is your coagulant INR PT management, and second is the outcomes of the echocardiographically normal gradient drop. This is the one modalities that contrast echo is now established. Generally we don't used to practice, but so many doctors, in particularly Western world, and Dr. Sanyal from Eastern Railway was there. He was from Eastern Railway, and he went to the, basically now in London, there is a very famous in echo world as a Dr. Roxy, Roxy Senior. Yeah. So he was from railwayman and was a very expert in particularly famous for contrast echo, and he developed this with contrast echo, lot of contrast echo. Even acute MI, they are saying we used to do it. So many contrast echo is existing things for the. And last part is the echo is in the very 2-3 years it is being applied for this fetal echo. Fetal echo is also an important part when we have to see the cardiac anatomical structure at the developing phase of that, and we have to see particularly the RA, LA, LALV, not LR not it is useful for LR but all other important for TGA, for fetal edemas, fetal heart blocks, fetal, so many important findings, and particularly 3D echoes where we can get the important for fetal echo. So these are the, in nutshells, commonly outcome. So sir, basically echocardiography is a diagnostic tools, aiding tools. The size from the big size machine to handheld laptop-like machines have already been existing. The common, if we see theoretically, there are the 100 points, but practically 20-25 points is the common clinical aids for that. And this technique is important. And we have done here 30 to 40,000 in last 10 years echo. And record echo, we don't have waiting time. We used to do it earlier. Our waiting time was 48 days. Now it is 48 hours. And particularly division patients, the same day we used to send him back. No patient will come for the next day, so that we can not only save the patient's agonies, but also the economically railway passes and all these things, because we have to give the report the same day. So that is the way, sometimes it is an important diagnostic tools. Ideally, in last meeting also I was telling you, it has to be kept in even the ED, our emergency department, ICU, and like that small tools, so that even in emergency we can see it and at least get some basic ideas. With this, I'll say thank you to all, and you should all having this last photographs I have kept, especially sir, this is the for the Doordarshan was invited me last very in India, this Calcutta Doordarshan, and this was my program display. So that's why I photographs I kept it, All India Radio and Doordarshan. Yes, that was from All India Radio. They have given us 1,000 rupees also, and but not for that, lot of blessings and wishing came from my geriatric older patient for All India Radio, and for this patient, whenever my patient used to come, they used to sit and congratulate me that sir मेरा रेलवे हॉस्पिटल का हमारा नाम हुआ. So it was a very fascinating for me. I wish all of your peace will be with me, and I will do more and more what good for. Wish you all the best, and best of Mahalaya and happy Durga Puja. Thank you. Any question I will be glad to answer. Someone follow.
I will differentiate between the myxoma and the clot.
Basically, myxoma, the one important part is that first myxoma site. Most of the myxoma origin is the atrial margin. So most of the will be pedunculated with one end from the your axilla. So most common is the LA, RA with the tone is the your one attached with the your E. But clot most of the near the valves, apex and this. Ideally both shape size will be same. These are the similarity. But always myxoma will be mostly pedunculated, attached to the atrial margin, and the movement of will be the free. The clot will be the your the over the valves, and it will be generally high. So that way you have to DD most commonly. We can rule out that it is not. Similarly, vegetations. Third is the vegetation. Vegetations will be your small over the surface, either on the valves, tips of the valves, near the valves, small in that, and many times transhospital we can even miss that.
Another important thing regarding this, many of the chest patients they are having this or pulmonary arterial hypertension.
Very important.
In echo, is there anything which is called shake bubble technique or like that? I want to know that.
Basically, the pulmonary hypertension. Most important part is that this question was asked by my postgraduate in software. I told you regarding the pulmonary hypertension, because I told you the pulmonary hypertension there are two eras. First, invasive area to non-invasive area. Earlier, non-invasive area, sir was thinking it was one gauge catheter was put earlier to get the important marker regarding the what is the pulmonary hypertension, how much is the pressure gradient, what is that. But that is been replaced by the now the good qualities and high-end echo machine. What finding we are getting? How we are calculating your pulmonary hypertension? We have to see the TR jet velocity. TR jet velocity is the your marker, and at the 10 mm. Suppose the TR jet velocity is the 55 mm, and your 10 mm RA pressure. So we are getting 55 mm. So your pulmonary artery hypertension is the 55 mm. Normal maximum is the 40 mmHg, up to 40 is the normal, and above 40 to 60 mild, 40 to 80, 60 to 80 moderate, and more is the severe. Just like your patient last case, it was a 90, but after treatment we don't get even the 30. Might be was one sildenafil to send on whatever treatment got it. So this is the way for indirect. One is the most commonly practiced is the RV velocity, systolic velocity, followed by adding the RS pressure. So these are the common way for practicing. But there are other 2-3 methods are also developed for those patients where there is a RV velocity is less. Then in that situations we have to calculate indirect method also. These are the two methods we use in pulmonary hypertension. But pulmonary hypertension is a very important. But two cases we always used to avoid in echo. It is a very frustrating. If we are not getting a good window, it is a very frustrating. One is the COPD, because heart is lung is obstructing. So whatever data will give you that may be missing.